The last step of the quality triology is the quality improvement, which aims at raising the quality performance of unprecedented levels. So here you're trying to work on the points of improvement. Let's not just say faults that you might face during the process application, and you try to work on them and you try to improve them, make them better, and then send them for planning if you need any changes during the process. The infrastructure necessary for quality improvement should be established. You would set your target for improvement. Of course, you need a team for every change that you are attempting to make, and you need leadership involvement for the sake of resource allocation. The JCI model of quality improvement does not differ much of the Jurans, and we're going to discuss this later. So, aspects of quality. The quality of healthcare has three main aspects. First of all, the measurable quality, where you try to assess your compliance to the standards, the practice guidelines, the protocols, the best practice, and so forth. And there are a set of differences between a culture of perfection and a culture of excellence. A culture of perfection is the culture attained by the organizations who are only trying to apply their standards. The standards being the accreditation standards, for example. They are only abiding to standards and they're not trying to cross them. They're barely making it. If you're barely making a success and you're barely on the stake as far as standard is concerned, so you cannot take any error, because any error could mean that you are below the standard within your indicators, and hence errors are hidden so that errors cannot be revealed to let's say the surveyors or so. And so every person who commits an error is eliminated from the system in order to make it more stable. You see, the culture of perfection is equivalent to the robesman at the circus, the robesman who walks on the rope. Any simple tiny mistakes, he falls off the rope, breaks his neck, and dies. On the other hand, the culture of excellence does not have a climax or an uppermost level where the standards are the limit. They are always on continuous improvement phase and continuous innovation. Errors, which are not due to negligence, are used as a teaching tool to allow people to learn from their mistakes and to allow people to avoid them in the near future and not to have to go through them in order to avoid them. And that's why errors are openly discussed. Since you have a wide range between your minimals, the standards, and your level, which is the excellence level, it's true that an error could cause a decrease in the performance levels or the performance indicators, but still you're above the standard. You're in a safe place, and so you can afford having errors happening. The other aspect, the second aspect, is appreciative quality, where it cannot be numerically measured, rather it's appreciated, it's qualitatively measured, which is the experience of the practitioners in your field. You can assess your practitioner experience by having an equal practitioner to assess his performance, and this is called peer review. Perceptive quality is the last category. It's the degree of excellence perceived by the recipients of care. Perceptive quality is the part of quality which is concerned more by the patients. It is based on the degree of care expressed by the healthcare professionals rather than the physical environment or the technical competence. So it's basically about the patient getting out satisfied and does not have to be much cured, which is covered at another aspect of quality, which is the standard application and so forth. Well, dimensions of quality. Dimensions of quality are the aspects of quality that you would have to satisfy in order to say that you've fulfilled the quality of service. Appropriateness, availability, competency, the confusing three, effectiveness, efficacy, and efficiency, where you would be assessing the good use of resources and the outcome of the service. Prevention and early detection of disease is among the dimensions of quality of care service in healthcare. Respect and caring, and last but not least, timeliness of the service. Now, to continue on the quality management models, we said that in JCI, everything is practically the same as DRANS, but the control is broken down to monitor and analysis. Everything is the same, but the analyze phase. Analyze is when you collect raw data by the meaning of data collected as true numbers and are not categorized, not applied on by equations, they're not plotted on graphs, they're just numbers, sets and sets of numbers. Try to process them, make them more meaningful, and can be used for improvement, and draw final interpretations and conclusions. Why would we do this? We would do this basically to compare our actual performance using indicators and using triggers to benchmarks, to the standards that we should be following, the guidelines that we should be following, or the regulatory body regulations, or with other organizations. The improve is prioritized by leaders. This is very important. Process to be redesigned, not to be corrected or improved when the process is new or a major change has to have upper hand rather than a correction. The Pareto principle is so important. We use the Pareto principle in our daily lives without knowing it. The Pareto principle is basically where you would try to prioritize the problems that you have and which ones you can work on first with your resources, knowing that most of the time your resources are limited, so you cannot solve all the problems. So one would try to work on the least number of problems that would solve the most of the sum of the problem. Process variation is the variation from a formal or usual state or from an assumed standard. Types of variation. It is based upon whether it's a clinical process, so a clinical variation, or a managerial process, which is called only process variation or managerial variation, non-clinical, in other words. As far as clinical variation is concerned, it can be either common cause or special cause variation. A common cause variation is a variation that is minimal. It always takes place. It's always there in the process. It's called a natural noise, where it's acceptable. You cannot change it. You cannot do something, you cannot correct it, because merely it's of the human factor within the process, of the incidental factors within the process. That's why it's called inliers. So process redesign or improvement is necessary to try to minimize, but you cannot flatten the process while you are trying to correct your common cause variation. Special cause, on the other hand, is an incident, it's an accident. That's striking the process from outside. The patient dropped out, somebody died, somebody was killed, whatever. But this is called a sentinel event, a one-time occurrence that just happens once. It's not there all the time. And the most important thing that the sentinel event or a special cause variation is a call for root cause analysis. Root cause analysis, where you try to analyze, seeking the root cause of the problem and try to improve it. Well, done with the triology now. We're moving on to the healthcare delivery settings. In healthcare delivery settings, we're going to discuss the different forms of the healthcare provision. This might not apply much to the Arab world. This would be applying closely correlated to the American community, the American healthcare community. We would be asked on the examination as far as definitions concerned through MCQs, of course. And we should be able to differentiate among them. The first one is emergency care. In emergency care, we have three categories. You can have a trauma center, which is basically a hospital that does nothing but emergencies. You can have an emergency room of the hospital, where an interdepartmental hospital which has pediatrics, gynae, surgery, and so forth. And it has a department of emergency medicine. Urgent care center, which are the ones basically found on the route or something when you're traveling or so. So the primary care, the patient would provide the patient with primary care, but stabilize him and transfer him to a higher level, which is either an ER or a hospital trauma center. An acute care setting is your typical hospital in a patient who was admitted to the hospital, who needs constant nursing care and medical care for the first 24 hours of the admission. Ambulatory care is the primary care and your outpatient care. Hospice. Hospice is very frequent on the exam. Hospice is mainly concerned with terminally ill patients, closely correlated to the patients with terminal cancer, stage 4, where it's inoperable, untreatable. You would have to monitor the patient, make sure that he has a good lifestyle, no pain, feeding well, and being taken care of. If he has a stoma to get changed, if he has dressings to be changed frequently, and catheters and so forth. You would stabilize the patient, make sure that he's living good till his days end. A home care is when a chronically ill patient, let's say for instance a hemiplegic or a paraplegic, he needs nursing assistance but does not need nursing assistance to be constant 24/7. That's why he does not need to be at the hospital. But he needs a nurse visit every now and then to assess him and try to help him and his family to go through it. In subacute care, on the other hand, it's the care that's very regular, provided by the hospital care providers, and does not need much of attention either. So, for example, wound care. A patient post-op who needs frequent wound dressings does not have to go to the consultant to change for him. Ventilator care are the patients with, for example, locked-in syndrome where he is paralyzed from the neck down. So the patient has his respiratory muscles paralyzed as well, and hence he cannot breathe. So for the rest of his life, he would be on a ventilator, and this would need him to be either at an ICU, which has limited beds, and hence he would be over-consuming our resources, or he can be at one of those ventilator care units. Long-term care are patients who do not need skilled staff and are in requirement of supporting care services.